Hi everyone, welcome to MedSurg 4. Today's topic is Chapter 57, Care of the Patient with Cancer. As you go through the chapter, please pay close attention to the key terms. Be familiar with the key terms, be able to define these key terms, and make note of them on your PowerPoint or within your reading. This slide and the following slide will cover the objectives that we will be discussing coming up. Note that if you can answer these objectives and if you can find them in your PowerPoint or within your reading, it would greatly benefit you and help you. Here's a list of the most common cancers found among both men and women. As you see, lung, colon, and rectal cancer are found in both men and women. Carcinogenesis is the process by which normal cells are transformed into cancer cells. Now stop right here and take just a few minutes to think about factors that can cause cancer. These can be external factors or internal factors. So before you move on to the next slide, just take a few minutes and think about factors or risk that can cause cancer. Okay, so now that you have determined some internal and external risks that can cause cancers, how do you think you could go about preventing those cancers from occurring? Well, some forms of cancer prevention are smoking cessation, eating a healthy diet, and a healthy diet contains fruits and vegetables, whole grains, low fat. Those are the aspects of a healthy diet. We need to avoid excess exposure to the sun. If you are in the sun for long periods of time, of course, apply sunscreen. Avoid smokeless tobacco. Avoid excessive alcohol consumption. So whenever you are coming up with your internal and external cancers, did alcohol consumption even cross your mind? So note that it doesn't say to not drink any alcohol. It just says to avoid excessive alcohol consumption. Exercising on a regular basis can also decrease your chances of cancer. So 150 minutes a week, which comes out to about 20 minutes a day. And think about it, if you walk 2 times a day, 10 minutes each time, that's 20 minutes. So get up and movement, any kind of movement on a regular or daily basis can reduce your risk of cancer. Also, adequate sleep, that's also a good way to reduce our risk, and getting regular medical exams. Now, know whenever you get a regular medical exam, that does decrease your cancer risk, but just note that if your patient does a self-exam, they do need to reach out to their provider if they find anything abnormal. And abnormal could be anything from a lump to a lesion to bloody diarrhea, difficulty swallowing. So if they note any type of irregular findings whenever they're doing their self-exam or their self-evaluation, make sure that they refer that to the health provider as soon as possible. So during detection of cancer, we want to identify the causes of the cancer. We also want to learn and practice self-examination, and those self-exams are what you're going to teach your patient. Note that a PSA is recommended for men over 50 and a mammogram for women over 40. So risk factors for cancer, these are the same things that you've heard over and over. These are not new to you, and so we're just going to go through these quickly. So smoking, of course, is a risk factor for cancer, as well as the use of smokeless tobacco. Our diet can also be a risk for cancer. So a high fat, high cholesterol, heavily processed food diet can increase your risk. UV exposure, as we know, that is one for skin cancer. So environmental. So when you think about environmental, think about maybe poisons or something leaching into your food or leaching into the ground. Those kind of things can be your environmental carcinogens. And then chemical carcinogens. Say if you work in a plant and you're not wearing proper PPE, and you're exposed to those kind of chemicals, those could cause cancer as well. Heavy use of alcohol, heredity. So if you have a family history of breast cancer, then there's a high probability that you're at risk for developing breast cancer. And as we age, aging also is a risk for developing cancer. Self-examination is very important. PSA is recommended for men over the age of 50. Note that if you have a patient who discovers a lump during their self-exam, that you should refer them to their healthcare provider immediately. But self-examination for men is very important. Just like men, women need a self-breast exam. Once again, if a woman discovers a lump or any abnormality during her self-breast exam, she needs to be referred to her physician immediately. Mammograms are recommended for women over the age of 40. And a Pap test. Do you know what type of cancer is detected during a Pap smear? So that would be your cervical cancers. So make sure that you are encouraging your patient to get a Pap test every year. The warning signs of cancer oftentimes are discovered by the patients themselves. They'll come in and they'll complain of these particular signs and symptoms, and when they do, that's when you need to do further investigation. So changes in bowel or bladder habits, such as bloody diarrhea or blood in the stool, some difficulty on urination. If they have a lesion that doesn't heal, that's also a warning sign of cancer, because it's got to be some reason why that lesion's not healing. Look at the location, do a little bit more in-depth history with the patient as you get that. White patches inside the mouth or on the tongue. Lots of times that's associated with the smokeless tobacco. So they may come in thinking that they may have yeast or something in their mouth, but really and truly those white patches are associated with the use of smokeless tobacco. Unusual bleeding or discharge, and that patient would probably need to follow up with a Pap smear for that. Thickening or lump in the breast or elsewhere. Indigestion or difficulty swallowing. Recent changes in warts, moles, or skin, and a nagging cough or hoarseness. So some of these are very common warning signs of cancer, and your patient's going to come in complaining of these signs and symptoms, and when they do, make sure that you do some investigation and follow up with appropriate testing. The next 3 slides cover the objectives for the next section. Take a moment and look in your ebook or in your hard book if you have one. It's on page 2027. There's a table that's labeled 57.2 that has some of the common terms that we're getting ready to review. So a neoplasm is a new growth. A benign is a not recurrent or progressive, and when we talk about benign, that means it does not spread to other areas or to other organs. That is benign. Malignant, on the other hand, does have abnormal cells that will spread to other areas. So a malignant tumor can progress and destroy surrounding tissue while spreading to distant parts of the body all at the same time. So that is malignant. A tumor is a growth, and it may be local or invasive. Now, a benign tumor is mobile, means it will move some on palpation, and it has a kind of a nice round shape to it. While a malignant tumor has an irregular shape to it, and it is solid, it is immobile, it does not move when you do any palpation with it. Metastasis is the process by which tumor cells spread from the primary source to a secondary source, I should say site, one site to another site. So you have cancer of the lung, and then it spreads to the liver. So you have it move from one site to another. Or you have breast cancer, and then you have lung cancer. It's moving from one site to another. Immunosurveillance, that's the immune system recognition, and it tries to destroy those newly developed abnormal cells. So your body's trying to destroy those new cells so that it doesn't invade other areas. Cancer cells differ from normal cells, and some of the ways that they do that is cancer cells arrangement is very abnormal. So their cellular arrangement is abnormal. Second, they have a very irregular shape. Third, they have an abnormal chromosome that makes up the cell. And fourth, they differ in the mitosis process. So cancer cells, they grow rapidly. Once they start, they're very rapid in growth. The cells are very irregular. They have rarely contained within a capsulated area. Those cancer cells are also capable of metastasis, and they have very little resemblance to the parent tissue itself. So there are several types of malignancies. First, we have carcinoma, which is malignant tumors composed of epithelial cells. We then have carcinoma, which are malignant tumors of the connective tissue. And then we have lymphoma and leukemia, and these are malignant tumors that originate from the hematopoietic system. So remember, that reverts back to your blood and your lymphatic system. So the pathophysiology of cancer. How does cancer even start? So first you have cells that are the basic structure of the tissues. The cells produce at a controlled rate. So they're producing, but they're at a controlled rate. Now sometimes the immune system destroys the abnormal cells, but sometimes the immune system fails to recognize that the cells are abnormal. And when that happens, you have cancer that develops. Now cancer cells, they can divide and multiply, and they do so in a manner that's not normal. So that's how that's the basis of the pathophysiology of cancer. Metastasis. Now, I'm sure you're all familiar with metastasis. You've heard of someone who's had a cancer and it has metastasized. What that means is they've had a cancer in one area, and that is the primary site. And now the cancer has spread to a secondary site. So when that happens, metastasis occurs. Now, once those cancer cells move to another side of the body, secondary tumors can grow there, and the cancer can spread there as well. However, the cancer is still named for the tissue of origin. Metastasis can occur by direct spread of tumor cells by diffusion to other body cavities, or by circulation by way of the blood and the lymphatic channels. So that goes back to the leukemia and the lymphoma that we just talked about. So once again, it can spread by either direct spread of the tumor cells by diffusion or circulation by the blood and lymphatic system. So there is a cancer classification system. There's clinical staging, there's TNM classification system, and there's also a Bethesda system. I'm not going to be testing you over these systems because it can be a little bit complicated, but I do highly suggest that you read over these so that you're familiar with that whenever you're reading someone's history and physical, or you're looking at someone's background, or you're taking care of someone in a cancer setting, whether it's hospice or if you work in an oncology center or something like that. So there are several diagnostic tools used to identify cancer. First being a biopsy. Now with a biopsy, that's where we're going to take a portion or a piece of tissue and look at it under a microscope. And when they're looking under the microscope, they are looking for those abnormal cancer cells. Remember, those abnormal cancer cells look much different than the regular or healthy cells. A biopsy can be done with a needle, and doing so is kind of like it's called a punch biopsy, and they take a needle and they stick it into the area, they pull out that tissue to put under the microscope. Another type of biopsy is aspirational. And with the aspirational, they're going to stick a needle in, but they're going to pull fluid out. And when they pull that fluid out, that fluid's going to go under the microscope as well. And they're going to look at that fluid for those abnormal cells. Another type of biopsy is incisional. Now with an incisional biopsy, they're going to take just a portion of the area and look at that portion and see if there's any abnormal cells. If they're not, they're going to leave that area alone. However, if they do find something abnormal in that incisional, they're going to move on and do an excisional. And an excisional is a removal of the entire area to get rid of all those cancer type cells. So make sure that you understand the difference between an excisional biopsy and an incisional biopsy. What are the difference between those two? And it doesn't matter what type of biopsy it is, remember that they're going to be looking under the microscope for those abnormal cells. Now an endoscope, you've all seen an endoscope, you've all seen an EGD, or you've seen a bronchoscopy, and when they do those type of scope procedures, they're also going to get a biopsy. So they're going to get that little clip of the little piece of that tissue, and they're going to put that tissue under the microscope and determine if the cells are healthy or if they're cancerous cells. Now when we talk about diagnostic imaging, it could be some of the following that you may see. It may be a nuclear study, it could be a CT, it could be an ultrasound. Now an ultrasound, remember that an ultrasound uses high frequency sound waves to see the location or the size of that tumor area. They may also do an MRI or a PET scan. Now remember, when they're doing these radiology studies, that they're looking at the structure of the tumor or the structure of the organ, and they're looking for those abnormal findings in the size and shape. Finding a tumor does not mean that the patient has cancer. You have to do some type of microscopic testing on tissue or blood to detect the cancer. Now all when we do a radiology study, what we're looking for is location, like I said, size, maybe a primary source, but that does not tell you that the patient has cancer, because there's a lot of things that can cause abnormal findings in an x-ray. It could be a benign tumor, which you know is not cancer. So it could be something very benign that they're looking at. So you don't know that it's truly cancer until you do some type of biopsy. You get some type of tissue or fluid from that area to look under the microscope to determine the type of cancer that it is. So some of the lab tests that you may see done are the calcitonin levels. They may do calcitonin levels. A CEA Now, whenever you do a CEA, it indicates that cancer is present. So that is a lab test that we can do. It's called a CEA, and that indicates that the cancer is present. Tumor markers. Tumor markers have come a long way. So now we do these tumor marker lab studies. A PSA is a lab marker. So a PSA determines prostate cancer. A CA-125 determines ovarian cancer, and a CA-19-9 is pancreatic or hepatobiliary type cancers. So you have these lab values that are markers, or they can identify those blood components to tell you that cancer is present. Stool for blood, like you can do a stool for blood as another lab test, or the patient can do that at home. You can give them instruction. A stool for blood, which is called a guaiac, and that's Guaiac, a guaiac, and that detects occult blood or hidden blood. So the patient might not necessarily see blood in their stool. They might not visually see it, but if they do a Hemoccult test, a guaiac test, it may show that occult blood or that hidden blood. And if they had that occult or hidden blood in their stool, that could trigger some more investigation that needs to be done to determine if that patient has some type of cancer going on. So here we're going to talk just a little bit more about the biopsy. Like I said, you have to put that tissue or that foreign body under the microscope. And this is used to confirm or establish a diagnosis of cancer and or the course of the disease. This is the only definitive way to determine the presence of malignant cells, and that is through a biopsy under the microscope. You have to see it under the microscope. Like I said, an X-ray does not confirm cancer, but a biopsy does confirm the presence of cancer. So surgery, nursing interventions. So if your patient has a diagnosis of cancer, they may have to have some type of surgery to go along with their treatment plan. So you want to make sure that you provide the patient with education about their surgery and how it is part of their treatment plan. Try to relieve some of their anxiety. Know that whenever you get a diagnosis of cancer, especially if it's metastasized, that is very disheartening to the patient. It's very upsetting. So they may have some high anxiety related to that. So do your best to give them some kind of comfort and relieve that anxiety. Make sure that you assess their nutritional status as well. Are they eating? What are they eating? How often are they eating? How many calories are they taking in? But assess their nutritional status. Nutrition is very important, that we keep their nutrition up because they need that added calorie and protein for the healing process. Make sure that you provide preoperative care, that it's very informative to the patient. Give them all that pre-op teaching. You learn that back in fundamentals: turn, cough, deep breathe, get up and mobilize, all those type things with the preoperative care. And the postoperative care, make sure that once they come back from surgery that you are seeing them turn, cough, deep breathe, use that incentive spirometer, and then they are up moving around. And then look for any community resources that may be available to the patient, maybe a breast cancer support group or a prostate cancer support group, some type of support group that's out there in the community that may be able to give them some resources. So one of the surgical interventions that are out there is a palliative care or a palliative type surgery. And when palliative surgery is done, that is just done to relieve uncomfortable symptoms. It is not a cure for the disease. So if they have a metastasis and there's a tumor involved and it's pressing up on their other organs and it's causing them difficulty in eating or difficulty in breathing, or it's pushing up on their the area and they're causing a lot of pain, they may do what's called palliative, and they may either debulk or reduce the size of that tumor in that area to give that patient some relief of that pain that they're experiencing at the time. Don't let the slide here deceive you. There's a lot of information that we're going to cover in radiation nursing interventions. So please refer to that area in your book for radiation nursing interventions. So first, we need to provide the patient with education. And they need to have education about what type of radiation that they're receiving, what can be the possible side effects, how can they reduce some of those side effects, and how can they take care of themselves when receiving radiation. Keep the skin dry, especially if they have the markers on their skin. The patient always has markers on their skin if they're receiving external radiation, say for lung cancer. You may see that patient have markings all over their chest, especially on the front. They do not need to remove those markings. Those markings need to stay there. So keep the area dry and clean, but tell the patient do not scrub those markings off. They're put there so that they know precisely where to put the radiation beams whenever they're doing the treatment. Always put the radiation sign in use on the door. Make sure that that's placed so that if anybody goes into the room that they know that the radiation is in use. And that way the visitors and any staff that needs to go into the room is aware of that, because we have to take special precautions when entering a room where there's radiation. Make sure to encourage those range of motions exercises. The patient needs to continue to move, and in just a moment we'll go into why that's important in just a moment. Make sure that you assess their skin daily, because radiation, believe it or not, can cause some superficial, almost sunburn-like activity on the skin. So make sure that you're assessing that skin on a regular basis. If you do see that the patient is developing some type of, I should almost say, sunburn-looking appearance or small burn appearances, please look into, let the provider know so that you can help that patient with some type of treatment to ease those type of superficial burns. Monitor that patient's INO. Make sure that their nutrition is good. Make sure that they're avoiding. Make sure they're having a bowel movement. Monitor that INO carefully, and their nutritional status as well. Make sure that they're eating and that they are maintaining some type of level of nutrition, because like I said earlier, nutrition is very key in the healing process. So let's start with the external radiation. Like I said, external radiation can cause some skin damage and some burnings and on the skin, and they do have those black, it almost looks like a Sharpie marker where they mark on the skin so they know where to put that. So we'll want to tell them not to remove those markings. Now we have internal radiation, which is an implant, and that can be the form of, it's called brachytherapy. And with that brachytherapy, that's an internal implant, and that can be in the form of needles, wires, seeds, beads, or catheters. And these type of internal implants go directly into the tissue. It's implanted into the tissue and it stays there for the duration or for a length of time that is prescribed by the oncology radiologist. They will determine the length of time that that implant needs to stay there. If you have unsealed internal radiation therapy, which could be, say, cervical cancer, and they use that radiation into the vaginal area. If they have that type of internal unsealed, because it's not implanted, it's unsealed radiation going on, you need to make sure that you have long handled forceps in the room for the radiologist to use. You as the nurse is not going to pick that up, but the radiologist can pick that up. And you don't ever touch any type of unsealed radiology device that comes out of your patient. So if your patient gets up or turns over in the bed and that radiated device comes out, that needs to be replaced, but you don't as the staff replace that. The radiologist has to do that. So long-handled forceps are left in the room at all times and do not touch the device. Also, with that unsealed internal radiation therapy, that patient has to be in a private room. Always a private room, and make sure that you have the radiation in use sign on the door. You as the nurse or anyone on staff has to limit your time in the room. So you go into the room, you need to have a plan already developed on what you're going to do with those few minutes that you're in the room. Because you should only be there just a few minutes. Limit that time. Cluster your care and limit your time in the room. Make sure that you are maintaining a safe distance from that patient. If you do not have to get up close to the patient, say for an IV or to hand them some type of medication, you need to maintain a safe distance away from that patient when you are in the room. Make sure that you have the radiation safety PPE equipment and wear that every time you go into the room to care for your patient. You'll also have a dosimeter, which is a meter that tells about your exposure and how much radiation you've been exposed to while you were in the room. Unfortunately, the patient has to stay confined to the room. They can't leave the room. They can't walk around in the hall. They may be allowed to get up and walk to the bathroom or to use a bedside commode or sit up in a chair, but they're not going to be able to leave that room while they have the unsealed radiation device in process. Appropriate trash removal, because it is radioactive. Make sure that you're using the appropriate trash removal systems and that linens are left in the room and they're picked up under strict supervision as well, using the radiation safety. No housekeeping should be allowed into the room. So yes, you as the nurse are going to have to take care of that patient. We just don't want everyone to go into that room. So you may also have to do all the blood draw, may have to be the one serving the tray and picking it up, but not everyone needs to go in the room. You need to limit the people that are in that room. And food should be delivered to the door or by the staff. The staff should be the one to take it in. And when I talk about staff, I'm talking about the nursing staff. You're not going to let someone from dietary into that room, because you have to dress out when you go in that room. You have to wear that radiation protective PPE every time you go in the room. So you don't want to have the lab dressing out and dietary people dressing out. So you as a staff nurse, you're the one taking care of that patient. You're going to be the one to dress out and go in there. Use as many disposable items as you can. Anything that can be thrown away should be what you use, because you don't want to have to decontaminate any objects that are in the room that you don't have to. So it has to go through a decontamination process if you remove items from that room, but you don't want to have to do that if you don't have to. Anyone who is pregnant or breastfeeding is not allowed in the room. So those people should not go into the room. So if you have a pregnant or breastfeeding employee on the floor, make sure that that nurse is not assigned to go into that room. So chemotherapy nursing interventions, just like the radiation nursing interventions, there's a lot that the nurse has to do and take care of when a patient is receiving chemotherapy. First, you need to make sure that you educate the patient about the chemotherapy treatment that they're going to be receiving, whether it's going to be oral or IV or sub-Q, what type of chemotherapy treatment are they receiving, and make sure that you provide them with adequate education. Monitor their nutritional status, because chemotherapy treatments can target normal cells just like they do the cancer cells. The patient is at risk for a nutritional deficit. So we want to make sure that the patient maintains their weight. It's very crucial that they maintain their weight and their nutritional status. We want to administer any antiemetics that the patient may need when they're receiving their chemotherapy, because that medication causes a great deal of nausea, and so we want to make sure that we are providing them with some comfort by giving them those antiemetics. Monitor their hydration status. Is the patient taking in enough fluid? We want to make sure that we are encouraging them to take in their fluid, and that when they take that fluid in, that they're also good output as well. So when your patient can develop what's called stomatitis, and that is irritation within the mouth that they can develop. When they have that, they are not going to want to eat or drink anything. So we need to make sure that we give them cool fluids, encourage soft food, and clean their mouth, do oral hygiene frequently, using a soft toothbrush. Now, chemotherapy is often used in conjunction with surgery. Surgery is used often to remove a tumor, and then chemotherapy is used in combination to prevent metastasis from the cells associated with that tumor. Now, but chemotherapy does have, the terrible side effects that we've talked about, but know that it can also have some impact on the patient's blood. So you may have a reduction in the white blood cells, which is used to combat infection. Remember that? So if they have less than 4,000, the patient's going to be considered leukopenic. So less than 4,000 is going to be leukopenic for your WBCs. The lack of neutrophils, which is the neutrophils are less than 1,000, that patient's going to be at risk for neutropenia. Now, when your patient has neutropenia, we're going to put them on neutropenic precautions. So remember, back in your MedSurg 1, when we talked about neutropenia, neutropenic precautions, remember the patient's door needs to be closed. You need to have a sign on it that says neutropenic precautions. No raw vegetables, no raw fruit. All that has to be cooked. No live plants in the room. If you have an infection process going on, you don't want to enter the room. Wear a mask whenever you're in the room to protect the patient from getting any type of infection from you. Thrombocytopenia, that's the decrease in platelets, and because you have a decrease in platelets, the patient can bleed. And if the patient begins to bleed because of that platelet reduction, make sure that you hold pressure to that site. And it may take 5-10 minutes or even a little bit longer to make that bleeding stop, especially if they are thrombocytopenic. And if you're doing oral care on that patient with thrombocytopenia, make sure that you're using a soft toothbrush as well. Pancytopenia, remember that's a reduction or cessation in all production of the erythrocytes, thrombocytes, and leukocytes. So you have pancytopenia can also occur. Make sure that you're familiar with these definitions and what your patient's at risk for developing should they have neutropenia or thrombocytopenia. So be aware of the precautions used for these types of penias that your patient can develop. Tumor lysis syndrome is an oncology emergency where you have the rapid lysis of malignant cells. It is a potentially fatal complication that occurs spontaneously or more commonly following radiation, biotherapy, or chemotherapy. Induced cell destruction of large or rapidly growing cancers such as leukemia, lymphoma, or small cell lung cancer. Those are the cancers that you will most likely see tumor lysis syndrome, or TLS as it's also called. So with TLS, you may have some elevated potassium, elevated phosphate, elevated uric acid, and also a low calcium. So you may see these alterations in your lab values when you draw that on your patient. You may see alteration in those values. So when you have that hyperkalemia, we know how we're going to treat that. We're going to try to bring that potassium down, and we're going to use medications to bring that potassium down. The same way with the hyperphosphatemia, the high phosphate, we're going to bring it down as well. With the uric acid, we're going to give the patient alpurinol, and that prevents the uric acid formation that alpurinol does. If the combination of diuretics and alpurinol doesn't work, then the patient may have to have dialysis. If you cannot get these lab work back in check, dialysis is the last resort for this patient, so we may have to do some dialysis treatment for them. But the goal is to decrease the potassium, decrease the phosphate, and decrease the uric acid. And to do that, we're going to give diuretics and alpurinol for that. So there's been a lot of developments in the treatment of cancers, and one of them is stem cell transplant. So an autologous transplant is from the patient themselves. And here's a diagram showing the process of retrieving the stem cells and then reinfusion the stem cells. So like I said, the autologous is definitely from the patient, and you'll see this sometimes as your cancer treatment. With a bone marrow transplant or bone marrow procedure, you're going to see that there's a large needle that's inserted, the bone marrow is retrieved, and then it is reinfused to a patient. Sometimes they do it peripherally, sometimes they do it through a central line. Either way, they use a filtering device, either when they receive it from the donor or infuse it to the patient. There's going to be some type of filtering system used there for the bone marrow transplant. So pain relief. Pain is a big issue in the treatment of your cancer patient. Remember, that is your fifth vital sign. Pain should always be your first concern with your patient, especially if it's someone who has advanced or a terminal type cancer that is not going to be cured. Giving that patient comfort is your goal, and your primary goal is to do that. It also gives the family some reassurance as well. If they know that their loved one is comfortable, they're going to be less anxious as well. So if the patient chooses not to take a scheduled pain medication, say a pain medication is ordered around the clock, you're going to give their pain medication every 8 hours or every 6 hours, and they are cognitive and they choose not to take their pain medication, just make sure that you document that they've decided not to take that pain medication at that time, and then go back and reassess them. In about 30 minutes to an hour, go back and reassess the patient and see if they would like to take it at that time. So, because the patient does have a right to refuse their medication at that time if they don't want it. And we can also have, oftentimes when you're having someone with pain, they may have a scheduled medication and they take it around the clock, but then they may have an added medication for breakthrough pain. That's not uncommon. So they may take an opioid around the clock, and then they may have some type of NSAID or another type of analgesic that they can have for breakthrough pain. So we want to make sure that you don't be afraid to give them that medication for the breakthrough pain. If it's ordered and they can have it, by all means, please give that to them, because like I said, pain is a top priority for these patients. Acupuncture, biofeedback, guided imagery, massage, and distraction can also be used. Those are just methods, alternative methods to pain medication that may help your patient relax, so that they're not as tense, and hopefully that will help keep their breakthrough pain in check and will require less less medication. But always keep that in the forefront that pain medication should be one of your first priorities for your patient with cancers. So cancer treatment and cancer care can be trying for both the patient who is receiving the care and the nurse who is administering it. So here's just a little mnemonic for cancer. So remember that the C is for comfort. So give your patient comfort at any chance you get, whether it is pain medication or just being a sounding board for the patient. And remember, comfort can also go to the family. The family is going through a trying time as well, so offer the family comfort as well. Altered body image. Depending on the type of treatment that they're having, remember those altered body images that can occur, whether it's related to surgery or alopecia, which is your hair loss, cachexia, which is the poor nutrition, and they have that real skeleton or emaciated look. Body images is concerning, and keep that in mind when dealing with your patient. Nutrition, remember, maintain that weight, encourage nutrition. It doesn't matter what they're eating. It doesn't matter if it's processed food, healthy food. It doesn't matter. But nutrition is a goal. Chemotherapy. Remember the side effects with chemotherapy, and keep that in mind whenever you are treating that patient who's receiving chemotherapy. Those side effects that are associated with it. Also evaluate the response to the medication. Sometimes medications need to be changed. Is the patient receiving adequate pain relief? If not, then maybe we need to reevaluate that pain medication. And also the delivery of the medication. Is it oral, IV, IM? How are they receiving that? So evaluate the response to those medications that they're receiving. And respite care for the caretakers. So know that the family is tired and they need some rest as well. So if you're able to spare a few minutes to sit with the patient or stay with the patient so that the family can step out, take that time to do so. As you go through these slides, if you have any questions, if you have any comments, if there's anything I can help you with or clear up, just please reach out to me and let me know how I can help you. Whether it's by Teams messaging or an email. And you guys have a great and wonderful day.